So I'm going to talk about complication avoidance in bigger surgeries, which certainly is something to deal with. Same disclosures as yesterday. So we're talking really, I'm going to focus on adult deformity cases. So big surgeries, scoliosis, adult idiopathic, de novo degenerative, some kyphosis, sagittal imbalance are sort of the spectrum of things we're talking about. And complications in big spine surgery are high. That's the reason all the minimally invasive things you just heard Juan talking about exist, is that the complication rate is significant in big surgery, and we need to always take it into consideration. So here's a study looking at the national implantation sample, looking for primary versus revision deformity operations. And in primary adult deformity surgery, 47% complication rate. So that is a high number, and up to 72% in revision surgery. So those are real numbers too. Those, if when you start counting complications, there's some debate on what you count as a complication. Is it major or minor? But you got to be aware of those numbers, and that means you got to do things to try and minimize those. If that's what the numbers are, sort of at baseline, we got to do whatever we can to make it better. Because if you don't, you're definitely going to fall on the wrong side of those numbers. Here's a nice paper looking at 12 patients. They did a prospective registry, which is sort of shows you what the problem in a lot of our literature is we get these retrospective reviews of databases and other things. But they looked at 942 patients. This was out of Vancouver, all with complete data. So they followed through really carefully through that year. All complex spine surgeries. 58% of those were elective, so a fair number of trauma and tumor cases fit in there too. So it's not all just deformity, but all major spinal surgeries. And they looked at the year before, so they used their hospital metrics, which we all use to look at complication. They had 23% complication rate for the year preceding this. When they tracked it prospectively, 87% with at least one complications, 14 mortalities, 14% intraoperative adverse events. Neurologic deterioration was significant, and dural tear 4.5%. So those are numbers that are probably more realistic in what we actually have with complications, but we kind of forget things when we go to look back at things. So when we talk about a deformity, so we know there's a problem with these. I always break it down into the steps really necessary to correct a deformity. There's a lot of preoperative work, and then there's a lot of intraoperative work that go on. Complications can occur at both of these steps. So any intraoperative complication and certainly postoperative complications generally start in that preoperative phase. So I always think about identifying the deformity. What is the balance? What are our fusion levels? Those factor into long-term and short-term outcomes. Then intraoperative, how we position, how we release. All of those are areas where we can have a complication occur. So we need to think about those pretty carefully. So when we think about those, we think about the intraoperative and postoperative complications. That's what we track. But their root is usually or oftentimes in the preoperative evaluation. So preoperative issues, well, we have to look at the alignment. So an inadequate assessment alignment is probably one of the most common things that leads to at least long-term negative impacts for the patient. You can look at that patient here who had a lumbar fusion. It's poorly aligned. It's not what that patient needs. It's setting up for junctional issues. They're not making it very long before they're getting revision surgery. Inadequate medical optimization is a huge issue. We always talk with our preoperative. We have a preoperative clinic that is a little bit easier to deal with because we can work with similar doctors all the time. But we talk to them, and I have a discussion all the time. I do not want medical clearance. I'm never sending you somebody for medical clearance. I'm sending you for medical optimization before the surgery. And those are different things. If they're just saying, yeah, they're good to go, that doesn't really help me in the surgery at all. I need them to pick out the weak spots and improve them so we can do better for our patients. And inadequate evaluation of bone health is rampant in the spinal fusion world. I can't tell you how many patients I see with failed constructs, pseudoarthrosis that come to me and ask, when was your last DEXA? And they tell me I've never had one. That's a bare minimum in these aging patients for an evaluation. So intraoperative issues. Poor positioning can be a big deal. So we get inadequate correction because we don't position them appropriately on the table. Nerve palsies in long surgeries are an issue. Little things such as getting their arms positioned appropriately so you can if you're bringing an O-arm in and if I'm doing a T4 to pelvis surgery and I'm going to bring the O-arm in to check my screws at some point, I have to make sure their arms are in a position that I can have them appropriate. I can slide them up to get it and bring them down because it's going to be in the way. If you've got the arm jamming in on their elbows or other things, you've got issues. You have to pay attention to that before you start, because once they're all draped, you can't see it anymore. So you need to plan ahead for all of those things. Ischemic optic neuropathy is a dreaded complication that certainly is positioning and time and blood loss dependent. Poor hemostasis is a big issue. So we know blood loss in surgery relates to complications. Transfusion relates to complications, and we need to pay attention right from the get-go. Whether that's just technique. So I always preach that speed comes from efficiency, not from hurrying. And if you're just trying to hurry along and skip steps, you're going to just be bleeding and bleeding and bleeding. You have to get hemostasis each step of the way. Poor tissue handling, same thing. Leaving retractors in for too long, getting ischemia on the tissues makes a difference in your wound healing and infection rates. Malpositioning of implants is still an issue, even with better technologies, it is still an issue. Dural tears obviously are something we are concerned with, but dural tears increase a lot of other complications. So it slows down your surgery. You have more anesthesia time. You get increasing blood loss because you're losing sort of the tamponade in that epidural space. And then you have more wound healing and infection issues. And spinal cord and nerve injuries certainly is a concern. We need to be careful with those tissues. So postoperative issues, inadequate VTE treatment or surveillance, sequential compression devices is sort of a bare minimum. Where they use chemoprophylaxis is still somewhat controversial. We put everybody on post-op day number 1. Early ambulation is key, though. Getting patients out of bed mitigates a lot of issues. Inadequate nutrition is an issue. Poor wound and drain management. You can't have somebody laying in bed. They've got C. diff and they're stooling all over everything. You need to pay attention to all of those. Right? We see it all the time, right? I saw it last week, and somebody that came in you got to pay attention to it all the time, not just in the hospital. If they go to rehab or they're going home, they got to pay attention to getting up and out of bed and all those things. And then lack of supportive services. So a patient that's going to go home needs enough support to go home so they don't bounce back. They just are, even in our center, we'll have patients go home, they'll come back to the ER just because they didn't have enough support at home, and they get readmitted to a medical service for really nothing. And that counts as a readmission for you. And when you start getting dashboarded on things, all of those things matter. So you have to pay attention to where are they going? Are they going to have enough support there? Can they function through there? It's one thing if you rush somebody out of the hospital on post-op day number 2 and you're like, wow, look at my length of stay was great. But if they're getting readmitted, that's far worse. So you need to make sure they're going to the right place. So if we're talking about reducing all these complications, I always think about it, what can we improve and what can we not? Some people just have bad diseases, bad issues that you just can't fix. So it's the modifiable versus the unmodifiable risk factors. So preoperatively, things that you can modify, smoking status. I do not operate on smokers unless it is an urgent issue with cord compression, new deficit, or tumor. Otherwise, everybody has to be completely nicotine-free for 8 weeks and pass a urine nicotine or urine continine test. Mental health is a huge issue. So depression and anxiety will reduce your outcomes. You can do a great surgery and the patient has major depressive disorder that's not well treated, and you're going to have problems. They're not going to do well with that operation. Bone health is key. I have patients that are on 3-month or 6-month or 12-month bone health plans before I'll do their surgeries to get them as optimized as we can. Obesity or malnutrition, those are two sides of the same coin, or sometimes you can have both in one patient, which is really the worst case scenario. Getting MRSA decolonization is an easy thing to do, and you should be doing on your patients that are getting implants. And then surgical planning. You hear a lot about PSOs and VCRs and all these cool techniques that we're going to look at in the lab. Do you really need one? They absolutely increase your complication rate, and they are not necessary in many, many cases. Are you getting appropriate correction? Are you planning your surgeries? And then PJK prevention strategies, you heard a little bit about it before. How you're handling those soft tissues at the top of a construct, whether you're tethering, whether you're doing something to buffer forces. And then multi-rod constructs for long-term rod fracture is an issue you've heard discussed here too. I put 3 rods in all my deformity cases. So things that we have, these are our sort of preoperative guidelines for people undergoing instrumentation at Northwestern. Hemoglobin, we're now setting a criteria of more than 11. That's still lower than I want it to be, but sometimes it's hard to get it above there. But we have an anemia clinic we're sending people to get iron infusions and other things if they're below that. BMI of less than 35, which is can be an issue, but I have patients on this whole weight loss and come in and get your weight check programs to try and get them there. You saw yesterday some good data that once we get over 35, our wound healing issues, our infection rates go up, and your length of surgery goes up. Your amount of tissue retraction goes up. It makes a difference. And those patients don't get up and move as well afterwards, so you start to get more thromboembolic issues, so it really matters. Hemoglobin A1C, a cutoff of 7.5 is definitely something that's there. Getting their vitamin D levels normalized is something that's not hard to do, but important. So you need to check that. Urine nicotine screen negative. We have an albumin of more than 3.5 threshold right now. Albumin is not a great marker for nutrition. We've been going back and forth with our nutritionists. Whether it's albumin, pre-albumin, none of these are great indicators. They're all acute phase reactants, so they can be variable at certain times. So it doesn't necessarily tell you the whole thing, but it's a number that you can check. And then making sure they're medically optimized. We're doing frailty screening on these patients, and then nutrition screening. So instead of just using an albumin, there's a 3-question nutrition screen that they can ask that would flag somebody as high risk, and that's still something we're working into our protocol that we haven't yet worked out yet, but you need to be asking those questions on how do we assess this better so you can do better for these patients. So intraoperatively, minimizing blood loss is key. Be efficient. Have a great assistant, whether it's a co-surgeon or a well-skilled fellow or resident. Anesthesia experience matters. Using TXA, that's been shown to reduce bleeding in surgery. What the true indications, dosing, contraindications actually are still not very well studied, but it's something we use on anybody that we think is a candidate for that, and they all get screened for it. Minimizing durotomy, protecting the neural elements, avoiding prolonged retraction anywhere on any tissue. Retract it for the least amount and the least amount of time possible. Infection prevention using Vanco powder is something that's fairly standardized these days. And then did you accomplish your alignment goals? Your intraoperative issue, did you get your alignment right, really matters for the long-term outcomes for these patients. So then post-op, get your medicine team involved early. Don't try and, treat the medical issues that you might not be an expert at. DVT prophylaxis again, and then early ambulation. So when I talk about alignment goals, what are my alignment goals? They're relatively straightforward. I'm trying to get their C7 plumb line under 5 centimeters, their PLL, there's a whole plus or minus 10. I'm firmly in I want to be in the range of normal camp. I don't want it to be 0. I never want the lumbar lordosis exceeding the pelvic incidence. I think that leads to junctional issues at an accelerated. I think that's overcorrection. I want to be within that normal range. And the older they are, the more barely I want to be in that normal range, but I always want them in that range. And pelvic tilt less than 20. Coronal balance is easy to say what you want, a little bit harder to achieve. So again, you've heard a lot about alignment. This is sort of how I would standardly assess somebody. This is an easy patient because they're fused in flat back, so that makes it easy, but they had an L5S1 disc. When I calculate it out, I calculate a C7 plumb line. I calculate a pelvic incidence, that's 58 degrees here. I calculate a pelvic tilt, that's 35, so if I want 20, I'm going to add 15 to my correction. Then I measure how much correction I need if I was going to do an osteotomy, say that looks like that would be 35 degrees. And then I sort of calculate and make sure those all are going to match up. So if I'm thinking I need 35 degrees plus 15 for my pelvic tilt, that's 50 degrees of correction. If I gave this person 50 degrees of lumbar lordosis and she had 0, does that put me within my 10? It absolutely does. Then I just have to actually execute that. So I did a 5-1 ALIF and got that there, then a PSO to get it back to aligned. But you need to check that in surgery. I can't tell you how many people come to visit us and come watch, and I ask, and I say, what do you do for intraoperative imaging? They go, I get a fluoro shot. Unless you have a fluoro that can stitch your images or do something pretty fancy, you can't tell. So every single patient that we do a deformity correction gets a 36-inch film on the table. Now, is this as good looking as a 36-inch film off the table? Absolutely not. But I can get in there and measure and make sure I actually achieve that alignment goal before we start closing it up. And I scrub out every time and measure the film myself. I don't eyeball it from across the room. I physically break scrub, measure the film, and make sure it's okay. So if we're trying to get appropriate fixation, we all put in screws. Thoracic pedicle screws are no big deal these days, right? So we think it's easy. They're not always easy. So this is a pretty rotated lumbar curvature here with pedicles that look like this. So if I'm going to get that spine corrected, I need to get a screw in there, and how you do that is really the key. This is just a video of that screw going into that right-sided pedicle. I just want you to pay attention to the angle this screw goes in at, right? So again, I don't use fluoro or nav or anything for these, but you got to know your anatomy. That angle, right, looks like it should be going right through the spinal canal in a normal patient, but that's right where it wants to be, and that's where that screw goes, right down the barrel of that tiny pedicle. You need to be able to do that to be able to execute these surgeries. So if you miss that screw, what do you do? The question is, do you really need it? So number one, if we don't need it, we'll skip it. Number two, maybe a new trajectory. You put a hook, a wire, do you cement, augment? There's lots of options to do that, but it gets difficult as you go down. But they're all techniques you need to know, right? If you look at biomechanics, if you switch a thoracic screw from a straight forward to an anatomic trajectory, you get something, but you lose, some strengths. If you go in-out-in screw, again, 64% of what an intact screw would be. Hooks, you get 60 to 70% of. So there are options, but they're all weaker than you started with. And the weaker your fixation point, the less you can pull. You got to sort of temper enthusiasm. You got to release the spine more. You got to do something to make sure you get that done right and still accomplish your alignment goals in that surgery. So when you look at the safety of these are some studies on thoracic screws. I just got some good pictures in here. I won't belabor it too long. Lots of screws placed for lots of patients, or lots of high-level surgeons. 10% malposition rate in here, but dural tears, pneumothorax, transient paraparesis, those are big deals. You don't want to have those happen in your surgery. So you need to know your anatomy. You need to know how to place a screw, whether it's freehand, fluoro, nav. What's your technique? Get it right. Wancho that that fluoro shot where it's a little bit rotated. You got to make sure you're getting things lined up and right, so you're doing it appropriately. The navigation we were talking about a little bit yesterday. You got to make sure that it's accurate. If it's inaccurate, it's dangerous. Here's one. Screw malposition can be significant. Lots of historical images of screws going in and out the wrong place. See pictures here. Screws into lungs, right? That's always a bad thing. Look at. I'm just showing a few different screws. Medial. Anteriorly perforating vessels. Here's some nice case reports. The screw in the aorta, and then they go and show you that when they go back in, you can see the dent in the back of the aorta as they're trying to pull this screw out of there. So that's bad, obviously, but not too bad, because here's one that they're showing it inside the aorta. So when you get an inside the aorta view, you did worse than your outside the aorta view. But you don't want to place those screws, right? That's a hard discussion to have with somebody, and these are lucky, right? They figured out these and then were able to fix them. It's when it's catastrophic bleeding or issues. There are reports of cardiac tamponade from people putting into pericardium. All sorts of issues can be there. Reports of pneumothorax from things going laterally. So the complications in screws are not small. It is like a part of the procedure we just take for granted now. You expose, you put the screws in, and you go. You have to pay attention to each and every step, and getting those in. That's a pretty small channel sometimes with some really critical structure. You got spinal cord on one side, aorta on the other side. Those left-sided screws, particularly in a rotated scoliotic patient, you need to be careful. Again, here's a case report of intracranial hypotension from somebody who put the screw fully in the canal, right through the dura, leaking CSF around it. Can be difficult to treat. And the problem with all this is, in a deformity operation, the screws are not the hard part. Right, that's not the hard part. There's some risk to it, and you need to pay attention. But the osteotomies, when you start cutting through the bone, that increases your risk. So whether it's bleeding, nerve injury, your durotomy risk goes up significantly. Rod placement, you have to get those in. You have to get it in well, and you have to get them aligned. And you have to do so without bending your rod 1,000 times and weakening it so it's just going to break on you. And then your arthrodesis, you have to pay attention. These patients, if they don't fuse, these rods are absolutely going to break. Even if they do fuse, these rods can sometimes break, it turns out. So you need to pay attention to good technique, good graft material, and making sure you're really meticulous to the arthrodesis. That's at the end of the surgery. You've done your x-rays. It's been a long day. You want to be done. You got to pay attention to that step. It is critical for long-term outcomes. So we look at some of the osteotomy data. This is an SRS M&M database, which again is retrospective, so it's probably not catching everything. But they looked at a number of cases for sagittal imbalance, looking at different osteotomies, 28% complication rate in SPOs, 39% in PSOs, 61% in VCR. So we think these are cool, sexy techniques, but the complication rate goes up with each one you do. Here's one looking at PSO and VCR, looking at complications. So PSO had done for different reasons, but significantly different. Major complication in the PSO here, 38%. Major complications. All complications, right? They're 53. If you look at overall total complications, 102 complications in 87 patients. So when your complications outnumber your patients, it's a big deal. So, and finally, the preoperative workup. So we've done something at Northwestern that I'm sure you all hear about, and most places have sort of developed some type of protocol. But identifying the medical risks is something that we're not very good at, so we need to get people to help. So cardiac, pulmonary risks are kind of easy to pick up. Somebody with a bunch of stents are easy to see, or they had big open heart surgery. It's not hard to figure out. But pulmonary issues can be a little bit harder to sort out. Hepatorenal issues are scary. Those patients do poorly with surgery, and you need to have somebody that's looking at those. Nutritional issues are easy to miss, and you need to pay attention, and the psychosocial issues are really key. Anxiety, depression are really important to identify and have treated. And my rule on people is, not only do you have to have your depression treated, you have to be able to tell me who's treating it for you, because we're gonna rely on them afterwards. You can't just say, yeah, I'm on an antidepressant and doing fine. I wanna know, how are you treating it, how well is it going, and who's doing it for you, because you're gonna need to follow up with them shortly after this. So we started our high-risk spine protocol in 2005 after an adverse event, so we're going on 13 years now. Our factors have not changed. We sit down, I'm in the process now of reviewing it probably for the third time and reorganizing the protocol. It's still more than 6 levels, more than 6 hours of planned surgery. Anything anterior, posterior, anything staged or age greater than 80 are sort of automatic, easy criteria to trigger the protocol. So we started in January of 2007 with this, and it's been published. I won't belabor it in the interest of time here. But you can see some medical criteria: coronary artery disease, CHF, cirrhosis, dementia, emphysema, renal insufficiency, pulmonary hypertension, stroke. Those are medical criteria that are sort of big deals and put you in a high-risk category, so you need to pay attention. But we have a whole protocol of preoperative evaluation and pathways for patients, preoperative testing, intraoperative verbal and written communication, verbal communication, written documentation, what we're going to talk about and when is a part of it. You can see all the things we look at. We have transfusion management protocols, neurologic testing, how we do it and what we do. OR temperature is a part of the protocol because patients getting cold matters. And then you can see what we check as we move through the process. There's a protocol that we follow, labs and when we do them and when we check them. So we're doing things in a systematic way and not missing steps. So the question is, does that work? Well, we think it works quite well. We published it in 2007. This was a study looking at, is it something you can actually follow? And we had greater than 30 attending anesthesiologists. We have a dedicated neurospine team, but 3 o'clock rolls around, people start switching up, you get call coverage. So more than 30 attending anesthesiologists, more than 100 residents and CRNAs participate in the care of these patients over the time period we looked at. And we only had a 2.6% protocol breach. And you can see how extensive the protocol is. So most of the time, those people, even if they weren't our dedicated neurospine people, could follow that protocol and get us standardized care. So I know what I'm getting out of my anesthesia team. I don't have to worry about what's going on on the other side of the drape. I can focus on what I'm doing. We looked at cardiac events in these patients, and it turns out that cardiac morbidity is higher than you'd ever predict. The RCRI is the Revised Cardiac Risk Index. Is something they oftentimes use to risk stratify. It's inadequate for spine surgery. It's just a bigger operation than they think. We found 9% cardiac morbidity in our patients when they'd be predicting like 0.5%. Only 0.2% of ST elevation MI, so pretty rare, but 1.8% of non-ST elevation MIs. But other patients had some transient arrhythmias or have a slight troponin elevation without any other signs. And then we looked at a transfusion model, how you can predict transfusion in surgery. So we've been able to mine a lot of data out of that. So we certainly see improvements. We have shorter hospital stays, shorter time in ICU. Patients don't stay intubated after big surgeries like they used to. And we certainly have better communication on our teams. So when I think about this, what do I think about when I'm looking at a patient for surgery? Number one, are they a candidate for surgery? You have to have solid indications. For big surgery particularly, you have to go in knowing that I'm doing this for a very good reason and it's going to stand up to scrutiny. Pain resistant to non-surgical measures, and they've got to have tried some non-surgical measures. Neurologic deficit due to the deformities, why I corrected deformity. If they've got a radiculopathy at L4-5 and a fractional curve, I'll just treat L4-5. If they've got an L2 and L3 radiculopathy at the apex of a main lumbar curvature that's due to just collapsing down, you generally have to correct that deformity to get that opened up. And radiographic progression is pretty rare in adults to be a main driver for surgery. Usually it's pain that gets you there, or pain with starting to get some neurologic symptoms. Are they medically and socially appropriate for the surgery? Can they handle it, and can their family handle it and help them through this process? Is their bone good enough for the surgery, and is it able to heal? I always tell patients, listen, I can make it look really nice on the table, and you're going to stand up, and if it starts pulling out of the bone, your screws are loosening, you're going to be less happy than you are right now, so we need to spend the time up front to get ourselves in shape for surgery. Do they understand the loss of motion of that surgery? T4 to pelvis, T10 to pelvis is a big operation. It's life-changing, and it can never be undone. Patients are absolutely going to dislike the stiffness that comes from that operation. I think that's underestimated a lot of the time. Their symptoms have to be bad enough to justify that motion loss that they're going to get after surgery, and you really have to counsel them on that, because no matter what you say, they're still not going to understand it until they get it done. So you have to get them as close to that as possible. Do they really understand the risks? Level selection, like, do you need to go to the sacrum and pelvis, because that has a big driver in terms of in terms of that stiffness that they experience. How high do you need to go? What do you pick your levels? That's a whole nother talk. What's your PJK prevention strategy? Because you do need to have one. Making sure you get appropriate alignment and what you use for a transition of force. You can't just put a big stiff rod on a big huge screw at the top and with overcorrection and expect that not to fail. That's going to junction for sure. And when do you say no? Saying no is not a bad thing. If an appropriate operation is not possible, so if somebody needs a deformity operation, but you think, well, they're not healthy enough, so I'm going to try something small, that's generally a bad idea. The medical risk is more than you think this patient can tolerate. That's a bad idea, right? You're just going to get into trouble and be regretting it and be in a situation that's tough to deal with. The surgical risk is too great. You think that either from a neurologic standpoint or from just a bone healing standpoint, you don't think it's going to heal or last. You got to think twice. And then the patient's psychological comorbidities are too great. I can't emphasize that enough. You can do a great looking operation in a patient that's psychologically not prepared for that surgery, and they will never be happy, and you will never be happy when they come back to the office. Thank you.